Hello guys. Welcome to my channel Psychology Point. Today we are talking about the psychology of people who pretend to be happy. So let's start. East Asian and South Asian male immigrants report some of the highest levels of acculturative stress among new arrivals. Yet, they simultaneously record the lowest rates of clinical help seeking. We are looking at a demographic that originates from some of the most densely populated regions on Earth, including China, Japan, and South Korea. This trend holds identically for immigrants arriving from South Asian countries like India, Pakistan, and Bangladesh. The sheer scale of this population makes their absence from mental health clinics statistically glaring. A lack of patients in the waiting room is often misinterpreted as an absence of psychological distress. The data shows the exact opposite. The distress is severe, but it is simply bypassing the clinic entirely. The standard Western clinical model relies on a pathway that requires voluntary emotional vulnerability to move from distress to treatment. The East Asian and South Asian immigrant reality follows a different pathway, hitting a wall of cultural stigma where admitting a need for psychological help equates to an unacceptable loss of face. Because the distress cannot be expressed in a therapist's office, it reroutes, forcing psychological pressure into externalized, often destructive behaviors. A mental health infrastructure built on the prerequisite of open emotional confession will systematically fail any demographic that is culturally penalized for losing face. Clinicians categorize this specific manifestation as masculine depression, which operates distinctly from the standard diagnostic criteria found in the DSM. At the core of masculine depression is a condition known as alexithymia, defined as the literal inability to verbalize or identify internal emotional states. Stripped of an emotional vocabulary, the body processes the trauma physically. The depression surfaces as somatic illnesses, translating psychological stress into chronic physical pain. When physical symptoms fail to relieve the pressure, the pathology escalates outward, manifesting as substance abuse, risk-taking, and interpersonal violence. To treat this, practitioners cannot wait for these men to walk into a clinic. Psychological care must be embedded within a high-utility, socially acceptable environment to bypass the stigma barrier completely. For new immigrants, the most universally accessed, socially mandatory environment is second language education. Treating masculine depression requires a masked intervention, effectively smuggling clinical therapy inside the structure of a second language classroom. To understand why this intervention is mechanically necessary, we use Geert Hofstede's Cultural Dimensions, a quantitative framework that measures the psychological baselines of different societies. Data comparing Asian cultures against Anglophone baselines reveals dramatically high scores in uncertainty avoidance and collectivism for Japan, China, and India. This measures a tolerance for ambiguity, reflecting an extreme intolerance for unpredictable situations and strict adherence to established norms. Immigration shatters those norms. The transition into a host country strips away the structured hierarchy of a collectivist culture, leaving the individual isolated in a landscape of total ambiguity. During this period of intense destabilization, the pressure to uphold traditional masculine family roles remains intact. Asking for help signals weakness and a failure to provide stability. For an East Asian or South Asian man, hiding psychological trauma is a mathematically predictable survival mechanism designed to prevent social exile, rather than a symptom of medical denial. This period of early immigration is known as the disintegration stage, marked by extreme cognitive overload and an acute threat to individual identity. When these adults enter a second language classroom, they are forced into similar states of high ambiguity and vulnerability simply by trying to speak. As language performance anxiety increases, acculturative trauma increases simultaneously. A simple syntax error triggers the exact same fears of social rejection and loss of face found in the outside world. This is exactly why traditional therapeutic approaches can actively harm this demographic, as demanding immediate personal vulnerability in an already high-stress matrix only accelerates the patient's retreat into silence. Any effective intervention must offer profound psychological distance, providing a way to process trauma without the patient having to explicitly claim that trauma as their own. Clinical drama therapy provides the mechanical bridge to resolve both language anxiety and clinical depression simultaneously. The first pedagogical intervention is the use of role play and mask work. Assuming a fictional character allows the student to practice intercultural speech acts safely, projecting their own acculturative shame onto the mask and insulating their actual identity from scrutiny. Jacob Moreno's clinical concept of psychodramaturgy, specifically the technique of doubling, serves a dual utility. Pedagogically, it helps correct sentence formulation, while clinically, it validates the patient's internal psychological reality by giving them words they cannot find themselves. Augusto Boal's distorted mirror technique forces participants to react to mismatched movements, exercising the individual's tolerance for ambiguity and safely processing the severe visceral shame of intercultural miscommunication. These theatrical mechanics successfully bypass the alexithymia barrier by making therapeutic processing kinesthetic and projected, rather than verbal and internalized. The ultimate systemic goal is the seamless integration of syntax and psyche. Increased language proficiency leads directly to increased intercultural competence, which decreases acculturative stress and builds psychological resilience. By explicitly training communicative competence in the classroom, the instructor is implicitly conducting emotional regulation therapy. This masked intervention relies entirely on the functional integration of two disciplines and does not involve patient deception. The students know they are practicing language through performance, and the absence of a formal psychiatric label is precisely the mechanism that keeps this high-risk demographic engaged. They are attending a class, not a clinic. By curing the literal linguistic isolation of the immigrant, the program dismantles the primary trigger for their destructive masculine depression. Standard diagnostic criteria fail to recognize trauma when it is shielded by cultural silence. For decades, the clinical field assumed marginalized patients must assimilate to Western medical models to receive adequate care. The professional imperative is clear. Practitioners must stop adapting the patient to the clinic and instead adapt the vehicle of delivery to the patient. The future of cross-cultural clinical psychology lies in engineering rigorous psychological interventions directly into the daily, functional survival environments our patients already inhabit. Okay, tell me, are you someone who always says, "I'm fine," when you're really not? Drop this emoji in the comment. Let this be the one place where you don't have to pretend. We see you. Okay, guys, take care, and don't forget to like, share, and subscribe my channel. Thank you.